Before we start this presentation, I would like to offer a formal apology. When I recorded this presentation, I was in a little bit of a rush, trying to get through the presentation very quickly because I was kind of under a gun. Unfortunately, when I recorded the presentation, I didn't realize how many times during the presentation I said the word actually. So I want to apologize ahead of time for the number of times that I said actually during the next 1 hour presentation. Please take it with a grain of salt, and I am currently making every effort possible to prevent that from happening again. Thank you, and enjoy the presentation. In this presentation today, we're going to cover different acute coronary syndromes of 12-lead interpretation. Not all of these are going to be true ACS imitators. There just might be some different deflections on the EKG that might not look like an ACS, but we're going to talk about the different problems that you can have that may actually throw off your interpretation. The first one I'm going to actually talk about is hypokalemia. Hypokalemia refers to a decrease in the plasma potassium concentration. Normally, the potassium is located on the inside of the cell. So when we have a cell over here, normally potassium is in higher concentrations on the inside of the cell, and sodium is on higher concentrations on the outside of the cell. So when we talk about hypokalemia, we're actually talking about a serum potassium that is less than 3.5 milliequivalents per liter. What that means is that there's a much lower level of potassium in the bloodstream itself. What that does is it actually changes the amount of potassium that's inside the cell, and there's more potassium actually on the outside of this. It causes more leaking of potassium to outside of the cell. Now, a result of something like this is that the cells actually become what's called hyperpolarized. To understand the hyperpolarization process, what you actually have to do is go back to the 5 phases of the action potential. So over here is actually phase 4. This is your resting potential, or your resting phase. Somewhere up here is going to be your threshold potential. What happens is in your resting potential, or your resting phase, normally the cell membrane has a negative 90 millivolt charge. What will happen in a hypokalemia is that the resting potential will become hyperpolarized, which means your resting potential, or your resting phase, is no longer down here at negative 90 millivolts. It may actually come all the way down even further, and I'm just going to make this number up here. Now your resting potential is down here at negative 110 millivolts. What this does is it actually makes the cell less responsive to a stimulus. What that means is if your resting potential is down here at negative 110, for it to hit the threshold potential, it has to get up to negative 70 millivolts. Under normal situations, if you have a 20 millivolt impulse, under normal situations here, it would have no problem hitting this threshold potential. But now your normal 20 millivolt impulse that hits will not achieve threshold. Therefore, the cell will not be able to depolarize. So the issues with hypokalemia is that the cells are a little bit more predisposed to needing more electricity, or a higher millivoltage of electrical current, to actually depolarize the cell. Some causes of hypokalemia include a decreased potassium intake, as well as anorexia, fasting, fad diets, that kind of stuff, as well as an increased loss of potassium. So if people have diarrhea, polyuria, peeing a lot, vomiting, dialysis, any kind of diuretic therapy where you pee out a lot of potassium, all of those could actually cause a hypokalemic state. What exactly does hypokalemia look like on the 12 lead? Well, the P wave could become tall and symmetrically peaked at greater than 2.5 millimeters. Basically what that means is your P waves could actually look like that they're going to be peaked like this, that would be your normal P wave, which would normally indicate right atrial enlargement. In this case, it's not a true right atrial enlargement that's causing the peaking of the P wave. It's actually the hyperkalemia. This actually gives what's called a pseudo P pulmonale. There should be no change in the PR interval. The QRS complex could be widened a little bit in much lower potassium levels, but it doesn't always happen. ST segments could become depressed, so the J point could actually be a little bit below baseline. T waves could flatten out and actually become smaller, and in some cases appear to have almost completely disappeared. But what's important is that as the potassium drops, the U wave will actually become just as tall as the T wave and eventually get larger than the T wave. So what that will look like is that your T wave has a very or your QT interval is very prolonged. Let me go ahead and give some examples here. So this would be an example of a rhythm with a person with a normal potassium. Normal potassiums are, depending on the text you read and depending on the hospital that you go to, usually 3.5 to about 5.0 or sometimes even 5.5 and milli equivalents per liter. In this case, this would be someone with a normal potassium. What you actually have is you have a normal P wave right here. It looks like you have a normal PR interval. The QRS looks like it's normal. There's a normal baseline right here, and then there's a T wave, but you do have a little U wave. In some cases, you will have a U wave anyway. But in this case, you're actually going to watch this U wave. As the potassium levels actually drop, oops, this is actually a typo here. As they actually drop, because it's a hypokalemia, the T wave and the U waves, as you can see here, the T wave looks like it's kind of getting smaller where the U wave is actually getting a little bit bigger. Now, if you weren't familiar with this patient here, you might actually think this is a weird notching of the T wave. Eventually what's going to happen is the T wave is going to appear to be smaller than the U wave. Now if you look at this and you're not really sure, this is going to be you're going to think that this is your QT interval. All of this right here, this is an enormous QT interval. Unfortunately, that's not the actual QT interval. The QT interval actually does stop right here. As potassium levels continue to become extremely low, what will eventually happen is you're going to assume that this is your J point over here, this is your ST segment, and then this is going to be part of your T wave all the way through here. This right here would be your apparent QT interval, very prolonged. In reality, though, it would stop right here. Hyperkalemia, on the other hand, is actually an increase in the plasma potassium concentration. It's not always a good idea to try to memorize exactly what QRS complexes look like based on what potassium levels. There are some people where there'll be potassiums that are high as 9 or 9.2, and it doesn't seem like there's a whole lot of changes on the EKG. So you can't really say every single EKG where a patient has a potassium greater than 7.0 is going to look a specific way. Please don't think that at all. But what does happen in a hyperkalemia is that you actually have an increase in the plasma potassium concentration. What happens here is that the cells actually have to stay depolarized longer. Now what happens is in the action potential, let me draw my action potential here. In the action potential, if you remember, what happens is during the depolarization phase, after you actually hit threshold, what happens is, generally speaking, sodium rushes in. In the phase 2 up here, you have your calcium, and that actually flows in because your sodium channel's closed. The potassium on the inside of the cell has to flow out to repolarize the cell. Once you get down here to phase 4 in your resting phase, then the sodium-potassium ATPase pump kicks in. Now the problem we have here is that because the patient is actually hyperkalemic, what's going on is there is a lot of potassium on the outside of the cell as well. Since these potassium channels are going to stay open until you get the right amount of potassium out of the cell. Unfortunately, there's a high concentration outside the cell. It's going to take longer to get more of the potassium out of the cell. So what's going to happen potentially in your action potential is that your action potential is going to be prolonged out quite a bit before it actually gets down to resting period because of this high concentration in the extracellular environment. This will slow down repolarization and depolarization of pacemaker cells as well. It'll also slow the conduction velocity through myocardial cells, and the problem is that the cells actually start to lose a lot of excitability because of this. Typically what happens in higher potassium levels is there is what appears to be some kind of interventricular conduction delay. And really it is kind of a delay because the myocardial cells are having trouble propagating the signal down through all the cells and the electrical current or the electrical conduction system. Second degree type 1 and type 2 heart blocks are very possible due to the interatrial conduction delay as well. Some things that you're going to see on a hyperkalemia is, first of all, the P wave is going to get flattened out and become wide, and eventually it will appear that the P wave will actually disappear. So what's going to happen is your normal P wave will eventually kind of start flattening out, and then it might actually get to a point where you might not even realize that there's a P wave in there. In reality, there might be, but we're not going to be able to see it. Because the P wave is actually flattening out and becoming wider, it will appear that the PR interval will actually become prolonged. The QRS complex, as the potassium rises, will eventually become slurred. It will merge with the T wave and become something that we actually call a sine wave, which basically looks very bad and very wide. ST segments will stay okay until they actually start merging. The QRS and the T wave start merging. Initially, the T wave will be tall and peaked and will usually be, that is can, and will usually be in the precordial leads and the midprecordial leads. That's where the T waves will actually be peaking a little bit. And when we talk about peaking of the T waves, what I mean by that is your T wave is going to be very symmetrically and almost completely pointed like that, almost like a needle top is what it will look like. U waves, there's nothing going on with the U waves there. Some causes of hyperkalemia is excessive potassium intake or a decrease in potassium excretion. Now what it has here is oliguria, potassium, sparing diuretics, decreased production of aldosterone. What happens in some patients is that aldosterone is responsible, it actually comes from the renin-aldosterone, angiotensin-aldosterone system. What will happen is the aldosterone will actually get into the kidneys and it will affect potassium excretion. If there is a decrease of aldosterone, what will happen is it will actually cause a decrease in the potassium excretion, which means you're going to be retaining more potassium. This would be a normal EKG or a normal rhythm strip with a normal potassium. And as the potassium elevates, what will happen is, as you can see here, your T wave will actually become symmetric and peaked. And it will actually become more peaked than that actually. Notice your P wave is actually widening out and flattening out a little bit. It looks like that your PR interval is actually increasing as well. So here it's 1, 2, 3, 4.5. So right now it's at 0.18 second, but it will actually continue to get wider and wider as your potassium rises. What's happening now is your P wave is somewhere over here. We have no idea where that is anymore, but your QRS complex actually widened out, and so did your T wave. Your T wave started to widen out as well. After a while, what's going to happen is this is going to widen out so much, it's going to be one big complex, just like this. If you were to know what you were looking at, this here is actually your QRS complex, while this here is actually your T wave. Now, if you just run on this person and show up, you're not going to be able to know that that's what that actually is. You might just see this wide, bizarre QRS complex. The one thing that I've always noticed with all the patients that I've ever run on that have been hyperkalemic with a sine wave, it looks like the patient has an AIVR rhythm, but they're conscious. Now, when does a person in an AIVR rhythm ever present as a conscious patient complaining of dizziness? And the answer is never. They are never like that. So if you have somebody who appears to be in a wide, bizarre, accelerated idioventricular, but they're conscious, then what you need to think of is hyperkalemia. That's what you actually need to think of. Let's move on to hypocalcemia, to the calcium issues. Hypocalcemia is actually a decrease in the extracellular total calcium concentration. What happens is calcium is responsible for the plateau phase of the action potential. So if we have our action potential here, what will happen is calcium being responsible right here, calcium extends the plateau phase and prevents it from repolarizing. So what will happen is if there is a low level of calcium in the extracellular environment, what's going to happen is it is going to take longer for the proper amount of calcium to actually flow into the cell. So what will happen in a hypocalcemic event is you'll actually have your action potential that will prolong the plateau phase before it actually starts to repolarize. This is what happens in hypocalcemia. Some causes of hypocalcemia include diuretics, hypomagnesemia, hypoparathyroidism, respiratory alkalosis, hyperventilation, as well as pregnancies. In the hypocalcemia, the two big areas that are actually affected is, first of all, your ST segment actually becomes prolonged. The reason it becomes prolonged is whenever you're actually prolonging your plateau phase and then it finally decides to repolarize, if you were to draw a QRS complex, there would be your QRS complex, there would be your plateau phase, and eventually you would hit your T wave way over here. This ST segment here would be prolonged longer than normal. The QT interval will also become prolonged because you start here at the beginning of the Q wave to here to the end of the Q wave. Your QT interval will actually become prolonged as well in a hypocalcemic patient. This would be an example of somebody with a normal serum calcium. As you can see here, your QT interval is right here. If you have a person that is in a hypocalcemic event, and that's actually a typo there, that's supposed to say hypocalcemia, what will happen is your QT interval will prolong, which is hard to tell if it's prolonged due to a calcemic event or if it's not. You'd have to have a comparison 12 lead and have a pretty extensive history on the patient as well. Now in hypercalcemia is an excess of serum calcium above normal levels inside the body, inside the blood. Because you have an excess amount of calcium inside the blood, what's going to happen is in your normal action potential, where calcium actually goes into the cell, what will happen in a hypercalcemic event, it will shorten, and I'm exaggerating just a little bit, it will actually shorten your plateau phase. The reason for that is because the inside of the cell will achieve its level of calcium a lot earlier. So once it receives it a lot earlier, it shuts those calcium channels and then you immediately begin to repolarize. Some causes of hypercalcemia, adrenaline. Take two. Some causes of hypercalcemia include adrenal insufficiency, hyperparathyroidism, vitamin A and D toxicities, and kidney failure. So like I said before, the problems with hyperkalemia is that the QRS will actually become a little bit wider, diffuse flattening of the T wave. The T wave will be shortened and the QT interval will be decreased because the plateau phase will actually be shortened. That area right there will be shortened. So this would be an example of a patient with a normal potassium. As you can see, the QT interval is right here. We can probably look at this and say that's 2, 5, 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 times 4 is 45, so that is 0.45 second. In the hypercalcemic patient, we can actually look here at the QT interval. Let's find out what this is. 1, 2, 3, 4, 5, 6, 7. So now your QT interval is actually 0.28 seconds instead of the 0.45, which is, I believe, what we counted before. Let's move on to digoxin. Digoxin, or any kind of Digitalis basically, is a cardiac glycoside that actually increase the force of contractions on a heart. Indications for digoxin include AFib, atrial flutter, congestive heart failure, and paroxysmal supraventricular tachycardias. Unfortunately, Digitalis is a fantastic medication, but it definitely produces a lot of problems in the heart as well, especially with chronic users. You could end up with premature atrial contractions, atrial tachycardia, junctional tachycardia. You can, in extreme cases, have a VTAC or VFibs, sinus bradycardias. You can even end up in AV heart blocks. The common ACS imitator that you actually have with the Digitalis is something actually called a dig scoop or a Digitalis scooping or ladling. And what you're actually going to look at whenever you see a dig scoop is you're going to look at your ST segment and your T wave, and this is basically what it looks like. It appears your J point will be difficult to find. It'll be somewhere in here, but it'll be difficult to find. You'll have this curving, and then it will come back to baseline, and then you will go just like this. So somewhere in here is your T wave, somewhere in here is your ST segment, but you're not going to be able to tell. A lot of people will see this and actually consider this to be subendocardial ischemia. This would be an example of a dig scoop. As you can see here, somewhere in here is my J point, can't really tell. Somewhere in here is my ST segment, and somewhere is my T wave. Where is it? I have no idea. So in this case, I would just look at the patient and say, well, I can't tell if you're having a cardiac event, but what I can tell you is that you do have a Digitalis scoop. And in this case, if you assume that the person is having an ACS or any kind of acute coronary syndrome, you always treat them as such, regardless of what you actually see down here. Procainamide is another medication that is actually used to treat dysrhythmias. It's an antidysrhythmic actually used to suppress ventricular ectopy. It reduces automaticity and slows interventricular conduction. And it's also given to patients that have PVCs that are refractory to lidocaine. Procainamide is a pretty neat little drug. Unfortunately, with Procainamide, what can happen is your PR interval could become prolonged. It will also increase your QRS complex. One of the criterion to stop administration of Procainamide is if your QRS complex widens more than 50% during the administration process. T waves could actually decrease in amplitude and also become more widened, giving an appearance of a prolonged QT interval. ST segments could become depressed, and QT intervals could actually be prolonged, just like I had said just a second ago. This would be an example of Procainamide. Like I said, there's a widening of the PR interval. There's a widening of the QT interval here. This is definitely much wider, and as well as the QRS could widen. So not only your PR interval, but your QRS and your QT could all become wider, all by administration of Procainamide. Tricyclic antidepressants can also cause cardiac effects as well. What happens though is it causes prolongation of the QT interval, so it'll give you a widened QT interval. It'll also increase the relative refractory period. Now let's move away from medications and actually start looking at some mechanical stuff here. First thing we're actually going to talk about is a pulmonary embolism. In this case, the pulmonary embolism, this is a really cool picture. This whole thing right here is actually your pulmonary embolism. That's a blood clot. It's actually called a saddle PE because it actually ended up here at the bifurcation and probably blocked a huge portion of the lung here. This might have been what killed this patient, since this picture is definitely a post-mortem picture. Some of the signs and symptoms of pulmonary embolism, as you can see, there's a whole bunch of them. The big thing here is that I want you to notice that 96% of them have tachypnea. There's also Rayleigh tachycardia, fever, which is interesting, sweating. You're going to have a gallop, maybe an S3 or an S4 gallop. All of this right here, don't worry about memorizing the numbers per se, but what you want to know is the classic triad of signs and symptoms is hemoptysis, which is actually a coughing up of blood, dyspnea, which is shortness of breath, and any kind of chest pain. If they actually have all three of these, you want to consider a pulmonary embolism. Unfortunately, they occur in fewer than 20% of the patients, so you kind of have to use a whole bunch of other symptomology about what's going on with the patient and to consider a pulmonary embolism. In a pulmonary embolism, you might be able to see electrocardiographic evidence of a pulmonary embolism. Now, I'm under the impression that it does not happen very often, so it's not like you're going to see this every single time. And I want to say it occurs about a quarter of the time, so maybe 25%. So it's not really a good diagnostic tool to use an EKG to try to rule out or rule in a pulmonary embolism. You should always use patient symptoms. First, what's going to happen is that you're actually going to have P waves, which are going to appear to give you a right atrial enlargement. That's supposed to be a right atrial enlargement. So you could have some peaking of your P waves. You're going to have something called an S1Q3T3, which basically means you're going to have in lead 1, and you're also going to look in lead 3. In lead 1, you're going to have an S wave. So you could have something like this, an S wave into your T wave. In the QRS complex in lead 3, you're actually going to have a Q wave, not necessarily pathological, but a Q wave. And then what's going to happen is your T wave is actually going to be inverted. So this is your S1 right here, your S wave, and your Q3 is going to be your Q wave right here, and your T3 is going to be your inverted T wave. That is your S1Q3T3. You could also have a right axis deviation, as well as your ST segment and T waves could change, giving you what appears to be a strain pattern in leads V1 through V4. The S1Q3T3 is actually the most common thing that people look for whenever they're looking for a pulmonary embolism. This was, at the time, the best 12 lead I could actually find, but we'll go ahead and look at this. This is a person who truly is actually having a pulmonary embolism. This was EKG was gotten off a patient who is having a pulmonary embolism. This is your S1, S wave in lead 1. This is your Q wave in lead 3, and here's your inverted T wave in lead 3. Now, this person does actually have a right axis deviation. If you were to look at this, lead 1, if you were to actually count the grid up and down, lead 1 is pointing primarily down, lead 3 is pointing, lead AVF is pointed primarily up, right together, left apart, gives you the right axis deviation, and you also have the S1Q3T3. Unfortunately, we don't actually have the right atrial enlargement P waves anywhere that I would really like to see. But if you do look at V1 through V4, especially over here in V1, what you can actually see is you can see a strain pattern in V1, and you can also see a little bit of a strain pattern in V2. V3 and V4 can't really see a lot of T waves in here, so I can't really see that. So your right atrial enlargement criteria we can't use, and the strain V1 and V2 is there, just not V3 and V4. They aren't there. But this would actually give us, with the patient presentation, the right axis deviation, the S1Q3T3, and the strain pattern in the precordial leads, in the septal leads would actually kind of point towards this person as having a PE, or PEP, as actually having a PE. Now let's talk about pericarditis. Pericarditis is actually inflammation of the pericardial sac that surrounds the heart. This could actually have an impact on cardiac function due to the inflammatory processes that are occurring in the pericardial sac. Just a little bit of review. Generally speaking, there are two primary layers of the pericardial sac. There's something called the serosa and another one called the fibrosa. The fibrosa itself is a fibrous connective tissue that is actually around in the pericardial sac. And what a lot of people don't realize is that the heart is not just freely floating inside the chest, just beating away. It is actually anchored to the great vessels, some of the great vessels back here, some of the pulmonary arteries and veins back there as well. Not to mention the fact that, as you can see here, it's actually connected to the diaphragm. What they don't show here in this two-dimensional picture is that the anterior aspect of the pericardial sac is also attached to the sternum. Now, the fibrosa actually does contain nerves, it contains blood vessels, and it contains lymphatics. The fibrosa is not just some dead piece of tissue that's sitting there and it's connected to all these areas. It does have to have some of the components that the rest of the body has. So whenever somebody does develop a pericarditis, it is very possible that an infection could get there through blood vessels, and then lymphatics could kick in for the immune response to try to fight it. And then you could also have nerves. As these chemicals are released from the white blood cells, they will stimulate nerves, the sensory nerves, which will cause people to have chest pain. Some causes of pericarditis. The first one I want to talk about is something called idiopathic, which basically means that the person is developing pericarditis and they don't know why. It's just a spontaneous form of an unknown cause of pericarditis. Trauma could actually cause it by direct or indirect trauma to the chest, blunt trauma to the chest. Pacer wires could actually make their way and actually punch through the ventricle, as it were, or the atrium, depending on where the pacer wire is, and actually damage the pericardial sac. Misplaced central catheters. I mean, it's very easy to sometimes go through a blood vessel and you don't realize it with a central catheter, and you could actually damage the pericardial sac. Infections can very easily cause pericarditis, and it could be viral, bacterial, parasitic, or fungal infections. Any of those pathogenic viruses or bacteria or anything can get into the body and cause it. The flu virus, of course, VZV, which is the varicella zoster virus, AIDS, or tuberculosis, any of those viruses can get into the bloodstream and anchor themselves into the pericardial sac, which could also cause pericarditis. Radiation therapy for radiotherapy for cancer could be a possibility if it's directed right at the mediastinum, only because it damages blood cells, which means that it could predispose it to becoming infected somehow. Immunologic conditions, such as an example as metastatic cancer, anytime that they say that a cancer has metastasized, what that basically means is that it's now moving. So it could start in one place and it could actually travel to another area of the body. Of course, since there are blood vessels that attach to the pericardial sac, you could very easily have a cancer that started in one part of the body and then moved into the pericardial sac itself. A couple more different causes of pericarditis. One of them could be some kind of connective tissue disease. For example, systemic lupus erythematosus could actually cause it, or just lupus. A lot of people consider it as lupus, which is actually a autoimmune disorder that actually attacks the connective tissue. Rheumatoid arthritis is another one that could cause pericarditis, an inflammatory response as the body tries to break down its own body, which is, of course, an autoimmune disorder. Some metabolic disorders include uremic pericarditis. Now, in a uremic pericarditis and renal failure, what happens is the urea that is processed in the liver that comes from the ammonia, as your body creates ammonia in the blood cells or in the body, as the body creates ammonia, the ammonia will travel to the liver will convert it into urea, and then the urea is supposed to be sent to the kidney to be excreted as urine. If the person is actually having a renal failure, then the uremic pericarditis occurs because there's high levels of urea inside of the bloodstream. And myocardial infarctions can also cause it. Transmural wall MIs can also involve the pericardium because blood vessels are attached everywhere. So if you have somebody that's actually having a myocardial infarction, it could also affect the pericardial wall itself. Some signs and symptoms of pericarditis include chest pain. Normally this chest pain is very sharp. It's precordial. It could be right in the center of the chest because the heart is, well, the pericardial sac is actually attached to the wall of the thoracic cavity, the anterior wall of the thoracic cavity. And what will happen is this pain will actually increase with inspiration, but more commonly when laying down or sitting up, which means if the person sits up or more commonly is leaning forward to alleviate the pain, then normally that means that it's a sign of pericarditis. You want to kind of consider pericarditis. Sharp chest pain with a person leaning forward to help alleviate the pain usually is a good sign of pericarditis. Tachypnea is common because it hurts to breathe because everything is moving inside the chest whenever you take a breath. So what they're probably going to do is they're going to have a faster respiratory rate because they're decreasing their tidal volume. To make sure you maintain the same minute volume, if you decrease the tidal volume, you have to increase the rate. One of the very common signs and symptoms that you'll have with a person with pericarditis, it's kind of difficult to determine this. Most books just say that there is a shoulder pain. There is a left shoulder pain. In this case, though, I want to explain exactly what the shoulder pain is. What it is it's actually something called a trapezius ridge pain. Now, this is actually pathognomonic for pericarditis. What pathognomonic means is that it is a one specific sign or a one specific symptom that only points to one specific problem. For example, if a person comes to you and says, I am having chest pain itself is not considered pathognomonic because what are some causes of chest pain? Heart attack, respiratory infection, pericarditis, we could go on. Chest pain is not pathognomonic. At the same time, if someone were to tell you, I did a 12 lead on the patient and there is a baseline sawtooth pattern noted, automatically you know that on a rhythm strip, if you see a baseline sawtooth pattern, it can only be one specific rhythm, and that is actually atrial flutter. It can't be anything else. So a baseline sawtooth pattern is pathognomonic for atrial flutter because it won't be any other rhythm. Trapezius ridge pain is pathognomonic for pericarditis, which means if you have trapezius ridge pain, you will only have pericarditis. Now, where exactly is the trapezius ridge? What you actually have to do is look at the clavicle itself. Okay, now here is a picture of the clavicle, and what we actually have is this is the anterior aspect of the clavicle. This is the posterior aspect of the clavicle. This is a clavicle where the sternum is over here, and actually the acromioclavicular joint is over here. So this over here is medial. This over here is actually lateral. The trapezius ridge of the clavicle is the lateral aspect of the clavicle on the posterior side of the clavicle. This is the trapezius ridge of the clavicle where the trapezius muscle actually attaches. So when somebody says trapezius ridge pain, this is the area that we are referring to. Some signs and symptoms of pericarditis basically include fever, a pericardial friction rub, which you can hear with a stethoscope. There's a friction between the pericardial surfaces, and it'll be rubbing as the heart beats. You can usually hear this best at the apex. Also, what you will have, which is kind of interesting, is you will actually have altered lab values. Because you're damaging heart tissue, you could actually have an elevated creatine kinase, or a CKMB. You could also have an increased troponin. So in a lot of these people, what they'll do is they won't just have to draw labs and do 12 leads, because you will have EKG changes consistent with ACS imitators and pericarditis, but you'll now also have elevated troponins and CKs. So is the person having a heart attack or not? You have to do a very extensive history to find out, should you be treating this patient as a heart patient, or are they pericarditis where you just give them antibiotics? The EKG changes, since I just mentioned them, the EKG changes that you will actually have on somebody that is having pericarditis, a lot of times the inflammation of the myocardium itself causes a couple things to change. The two big things that will actually change is that your PR segment will actually be depressed in some leads, in like your hexaxial leads, as to where you'll actually have some T-wave inversion and some ST segment changes as well. So if you look at a pericarditis, what will happen is, here's your baseline, this red line is your baseline, you'll have your PR segment depression with ST segment elevation, and sometimes you'll actually have a little notching there. So in this case, this is a great picture. Here's your baseline that goes right across here. There's your PR segment depression. There's your ST segment elevation. Now, in the precordial leads, especially in the anteroseptal leads, you may actually have ST segment, or I'm sorry, PR segment elevation with ST segment depression. Now, these signs right here, this is going to be global. You're going to have global ST segment changes and PR segment changes, which kind of tells me, is this person actually having a heart attack involving the entire heart? Maybe this is actually a pericarditis patient, but those are very classic signs right there of somebody on a 12 lead having a pericarditis. Here's a really good 12 lead of somebody actually in a pericarditis. What you will actually see way over here on lead 2 is there's your ST segment depression with your elevation. There's your depression with your elevation itself. Hypothermia is when the core body temperature actually goes below 35 degrees Celsius or 95 degrees Fahrenheit. They're actually broken into 3 different levels: mild, moderate, and severe. Hypothermias will also cause EKG changes on the monitor. So in a mild, moderate, and severe, in a mild hypothermia, what you're actually going to have is you're going to have a person that is having they'll have slurred speech, some uncoordinated activity, they'll be shivering, but they probably won't be thinking clearly. As you progress into a moderate hypothermia, the big thing here is that you'll actually have a change in the responsiveness, but then you will actually have a loss of shivering. And your loss of shivering usually is due to the fact that you've basically run out of energy to shiver. Your muscles have a finite supply of energy, and if you quit shivering, you're not warming up. You've actually run out of ATP to continue the shivering mechanism to try to warm yourself up. As you get into the severe hypothermia, your patient's going to be unresponsive. Pupils are going to be fixed and dilated. Very easily, somebody in this situation, as well as the moderate up here, you could very easily have somebody go into a ventricular tachycardia, or even more commonly a VFib. Respiratory arrest will be apparent only because of the fact that the respiratory rate and depth and effort will be so low and so bradypneic that it will appear that they're actually not breathing. You're not going to avoid treatment. You're still going to treat them as if they weren't breathing, but it will just appear that they're not breathing. In hypothermia, some causes could be an environmental, which is the most common cause of hypothermia. You could have metabolic disorders, which could actually slow down the metabolic rate of the body to a point where they will end up in a hypothermic state. Sepsis is a very common problem. As people become septic, initially in their infection, the temperature will go way up to try to fight the infection. But as the infection wins the battle, then the body temperatures will actually drop. Brain injuries and alcohol poisonings as well cause hypothermia. In a hypothermic patient, initially what will happen is the vasoconstriction will occur to try to shunt blood away from the extremities to try to conserve heat. Your heart rate, respiratory rate, and blood pressures will go up, and your metabolic rate will also go up as well to try to save heat, to try to generate heat. Muscular tone increases, which basically means that you're shivering a little bit. Shivering begins to generate heat and continues until about the core body temperature reaches 30 degrees Celsius, which is about 86 degrees Fahrenheit. At that point, you will actually stop shivering. Whenever you stop shivering, basically what that means is you have a depletion of your glucose and your glycogen stores, and the insulin doesn't have any more effect anymore, or your body just hasn't put out any insulin at all. What will happen is now that you've actually stopped shivering, you will rapidly cool off because you're not generating any heat to try to combat the cooling processes that are occurring inside or outside of your body. Eventually, your respirations will decline, blood pressure and heart rate will drop, pH will actually drop, becoming more acidic because you're not actually getting out any of the acids, you're retaining all of the carbon dioxides, and eventually your electrolytes will also become out of balance as well. Whenever you have somebody who is hypothermic, they will actually have some EKG changes. The most common EKG change that you will actually have is what's called an Osborn wave. And basically what you have is this big hump right here that is found just after the QRS complex. That's usually where you will actually see something like the Osborn wave, appearing to have ST segment elevation when in reality it's not. This is a person here who does have some hypothermia. I think this was a moderate hypothermic patient. In the midprecordial leads here, you can actually see that J point appears to be up here, and then you have this what appears to be a scooping here. All of this is due to the hypothermic event, just like that. Now, this is considered the Osborn wave in a patient who is hypothermic. This person was very cold, as you can see, and what's happening here is you're actually developing these global Osborn waves. You can see them over here, you can see them over here. Even if you look over here in 2-3 and AVF, you can see them over here as well. All of these are Osborn waves. They look like ST segment changes. They look like an acute coronary syndrome. In this case, I would probably be more worried about the patient having a hypothermic event. How do you treat these people? Pretty straightforward. You just remove them from the environment. Make sure that you're very careful with these people. If you are not careful with these people, the bumping around, the moving around, the rough handling can actually send them into a VTAC, or more likely a ventricular fibrillation. It will actually send them into a cardiac arrest. Make sure you remove the clothing. Assess for breathing and circulation for 30 to 45 seconds, not just the normal time. And just remember is that one thing to remember is that people are not dead until they are warm and dead. So no cardiac meds until you've at least gotten them above 30 degrees Celsius. And then at that point, you actually give them at prolonged intervals. Because if you give them at the normal intervals, what happens is as the patient warms up, the medications won't have any effect on the patient until the body warms up. Then when the body warms up, all of a sudden you have all these medications that you've been slamming into the patient during the cardiac arrest, and all these medications hit the patient all at once. Could actually cause them to not be resuscitated because of that. Early repolarization is very common in young, healthy adults, and I've seen a lot of 12 leads on a lot of people where I've seen some early repolarization on some young people. There is no pathologic implications whatsoever when you have an early repolarization. Most of the time they're seen in the inferior leads or the precordial leads. And basically all that is you have the J point with the notching. It might look like an elevated ST segment. A lot of times, though, the computers will actually identify the early repolarization, so you don't have to worry about seeing it or not seeing it. This is a really good example of a person with early repolarization. If you actually look over here in the hexaxial leads, what you will actually see here is as the QRS complex comes down, it kind of scoops and goes into your T wave. Now you might want to consider this as a dig scoop, but it's not actually a dig scoop, because normally a dig scoop will go below baseline, come back up to baseline, and then be flat. This doesn't look anything like that. So as you see the scooping here above baseline, it's hard to see where the J point is. You might actually consider this as being an early repolarization. A very common early repolarization pattern, especially in V4 and a lot of times in V5 and V6, is this is a really good pattern to memorize right here. That image right there is really good to burn into your memory, because the QRS will come down and then it will appear to come back up and then go into the T wave just like this. This pattern here is a really good idea to memorize. Finally, we're going to cover preexcitation syndromes. This is the last topic. So, preexcitation syndromes basically means that there are accessory pathways from the atrium or from the AV junction that causes an early depolarization of the ventricles. Now, this does predispose people to going into re-entry arrhythmias. Depending on where the accessory pathway is actually located, it could send them into re-entry phenomenons. The three fibers I'm going to talk about is actually the bundle of Kent, or the Kent bundle, which is very common in Wolff-Parkinson-White or WPW syndrome. But there's a couple other fibers that a lot of people aren't sure about or don't know about. One of them is called a James fiber. The other one is called a Mahaim fiber. The first one we're going to talk about is the Kent bundle. Now, what the Kent bundle does is, as you can see here, the Kent bundle is way over here. The Kent bundle actually bypasses the atrioventricular septum. So we'll say that this here is our atrioventricular septum. The Kent bundle actually bypasses this. So what happens is, as the signal is being held up through the AV node to allow for right atrial and left atrial contraction, what happens is the signal here is not held up, so it's going to go ahead and start depolarizing the ventricles. As it starts to depolarize the ventricles over here, it is not traveling through the superconductive pathways. It is traveling cell to cell to cell to cell. What that does is it actually slows down the signal, because it has to account for mechanical contraction. So what will happen is you'll have a P wave with a shortened PR interval, and then what appears to be a delta wave before you go into the normal QRS complex. In this case, what happens is the delta wave right here is the signal traveling through the AV node into the ventricle and traveling in a cell-to-cell format until the signal gets through the AV node, down the superconductive pathway, and actually catches up to the signal over here. Once the signal catches up, then you actually start to narrow out your QRS complex. The key criteria here, though, is that with a accessory pathway like the Kent bundle and WPW, you're actually going to have a short PR interval and a delta wave. Those are the two key indicators that you have a Wolff-Parkinson-White, WPW, or Kent bundle accessory pathway. Here, as you can see, your delta wave, you have your delta wave that comes up right here. This is the accessory pathway causing its effects on the EKG. Now, the rest of the signal that got held up in the AV node is going to do exactly what it's supposed to. As the signal goes through the AV node and travels down the right and left bundle branches, as it goes through the His bundle and it travels through the superconductive pathways until it reaches the Purkinje network, eventually it's going to catch up. Once it catches up, the rest of the depolarization will be perfectly normal. But like I said before, delta wave is one of the criteria. Shortened PR interval is the second criteria to determine a WPW with a Kent bundle. Now, James fiber, on the other hand, is a little bit different. The James and Mahaim fibers actually come from the AV junction area. In the WPW Kent bundle, it could be nowhere near the AV junction, where these other two are actually associated very closely with the AV junction. Now, what happens here is we're going to have the AV septum right here, the non-conductive AV septum right here, and what's happening is, as the signal is being held up here in the AV node, some of the signal is bypassing the AV node, innervating the His bundle, and then super accelerating itself through here. Some of the signal over here is going to try to make it through, but once it hits this area that has been innervated by the James fiber, this is already depolarized. So the signal that came through the AV node is going to be stopped. Now, the signal that comes through the James fiber is actually going to rifle down here through the His bundle into the right and left bundle branches and into the Purkinje network. What this will do is it will give you a P wave with a shortened PR interval and then a normal QRS. Since you are not traveling through any cells in the myocardial tissue, you're only traveling through the superconductive pathway cells, you're not going to have a widened QRS, you're not going to have a delta wave, but you will have a short PR interval. Now, a lot of people have actually asked me before, how am I supposed to determine a James fiber accessory pathway and a junctional rhythm? The only way that you can differentiate between a sinus rhythm with a James fiber accessory pathway versus a junctional rhythm is basically patient history. That is the best answer that I can give. If the patient knows that they have accessory pathways in their heart, if the patient knows that they specifically have this James fiber, then you can anticipate that the rhythm that you're looking at with the shortened PR interval at a rate of 70 is actually a sinus rhythm with a shortened PR secondary to an accessory pathway and not a junctional rhythm. On the other hand, if you're just looking at a rhythm and you have no patient history whatsoever, you can consider it as a junctional rhythm. So just consider it junctional until proven otherwise if there is a shortened PR interval. Finally, the Mahaim fiber. Now, the Mahaim fiber actually starts in or below the AV node and actually terminates in the ventricular myocardium. So what that means is the James fiber was up here and came down this way. The Kemp bundle was actually over here. The Mahaim fiber actually starts here in, we'll say, the bundle of His, and it will actually travel out a little bit and terminate out here in the ventricle. Or it could go the other direction. Point is, starts here, goes into the ventricle. Now, what that means is you will have a very normal PR interval. The reason you have a normal PR interval is you didn't bypass the AV node. In the Kent bundle, you bypass the AV node over here. In the James fiber, you bypass the AV node over here. In the Mahaim fiber, you don't bypass the AV node, so you're going to have a normal PR interval. But you will actually have a delta wave, because what's going to happen is the signal is going to travel through the AV node, start traveling down the His bundle. It's going to go through this signal and stop and start depolarizing a cell to cell to cell, while the rest of the signal travels down the superconductive pathway and catches up to the cell-to-cell depolarization. So like I said before, WPW has a shortened PR interval with a delta wave. What happens if you actually have a normal PR interval with a delta wave? In that case, you don't have WPW, you actually have a Mahaim fiber or an accessory pathway that's actually causing the problem there. So here are some examples of the Kent bundle, James fiber, and actually the Mahaim fiber. The Kent bundle, as you can see, which actually causes the WPW with the delta wave, which, by the way, this is the most common accessory pathway right here. These aren't quite as common, but they are still there. It's a possibility. But anyway, this is the most common. Criteria for this, just make sure you understand less than 0.12 seconds, which means you're going to have a shortened PR interval and a delta wave. A James fiber, you're actually going to have a shortened PR interval, no delta wave. It's going to look like a normal QRS and T wave right after that, but you're going to have a shortened PR interval. Remember, it is junctional until proven otherwise. Don't automatically assume that if you have a PR interval less than 0.12 seconds that it could be a James fiber as well. Always assume it's junctional until proven otherwise. And of course, the Mahaim fibers, you're going to have a delta wave here, but you're also going to have a normal PR interval because the Mahaim fiber, it does not bypass the AV node. The James fiber and the Kemp bundle both bypass the AV node. The Mahaim fiber does not, but it will still get you a delta wave. So in a Mahaim fiber, you'll have a normal PR interval with a delta wave. I hope you enjoyed this presentation of Acute Coronary Syndrome imitators for the 12-lead EKG. I do know that this material came very fast at you, so if you want to watch it again, please watch it as many times as possible. Take as many notes as you want. If you have any questions at all, please feel free to contact your lecture instructor. Thank you.